Welcome to this lecture on refractive surgery. The aim of this lecture is to give an introduction about the various techniques which you use in refractive surgery, and so that as a resident you have up-to-date knowledge about refractive surgery, because what we found is sometimes most of the programs are not giving you enough exposure to refractive surgery, so there's a lacking of refractive surgery education in our residents. So we start off our lecture with the different reasons why we opt for refractive surgery. So it is usually to correct refractive areas. Previously, people used to have it done because it was need of their job, like people who wanted to work in the police or the army, they would have it done. And some people would have contact lens intolerance. But with newer times and with advancing age, and especially with the internet generation, now it's more of cosmesis, frustration with the use of spectacles and contact lenses, and improved unaided visual acuity. So you can see it's started off from being a requirement to being just what a patient wishes. So I always explain to the patients it's cosmetic surgery, you can have it done, but obviously it runs its risks associated with it. So you need to have a careful examination by the ophthalmologist and then move forward. So before we go forward, they're just going to classify the various type of procedures which you use for refractive surgery. If you broadly classify them, one is Keratorefractive Procedures, the second is lens-based refractive procedures, and the third is combined lens and corneal refractive procedures. So some of them we'll discuss in detail, and some of them are outdated, so we will not spend much time on them. So we start off with Keratorefractive procedures. We see that the first one is incisional refractive techniques. So as you've probably heard about radial keratotomy, it is a procedure which used to be done years ago, but it's been abandoned now. But that was the start of treatment for myopic patients. Then we have astigmatic keratotomy, hexagonal keratotomy, limbal relaxing incisions or LRI, and opposite clear corneal incisions. Then we go on to lamellar corneal refractive procedures. Started off with freeze keratomileusis. Then we come on to epikeratofakia, and then keratomileusis in situ, and then automated lamellar keratoplasty, and small incisional lenticular extraction, and then we've got the corneoplastic. Then we move on to keratorefractive procedures in which we involve laser. So there are laser ablation corneal procedures, and they include PRK, which is very popular. Then we've got LASIK, laser subepithelial keratomileusis. Then we've got LASIK, then E-LASIK and C-LASIK. So these are actually the norms in society which you should know as an ophthalmologist, even if you're not doing them, because patients will probably know better than what you know in that instance. Then we come on to corneal shrinkage refractive procedures, which include thermal keratoplasty and conductive keratoplasty. These probably started off, but they are not in vogue quite a lot nowadays. So the other procedure which we have is keratorefractive procedures, which include corneal implants, which include intracorneal contact lenses. Then we have intrastromal corneal ring segments or intacs, and we have corneal tissue molding techniques, which is called orthokeratology. Next is lens-based refractive procedures, which is phakic refractive lens exchange, and then there is refractive lens exchange. Phakic refractive lens exchange means that the lens, the crystalline lens remains intact, and you place a lens in front of the crystalline lens, clear crystalline lens, and the iris, so it's space in the sulcus. While a refractive lens exchange is when the lens is exchanged for a new lens which is put in the back. Then we have combined lens and corneal refractive procedures, which include bioptics and trioptics. Preoperative evaluation is very, very important in patients with refractive surgery, and that is, I think, something which is not very keenly taken care of and leads to quite a lot of postoperative problem for the patients. So it involves good screening, history taking, and preoperative examination and counseling. The most important things in examination is visual acuity. You need to have a distance and near visual acuity with and without correction. And then you need to have a refraction, which needs to be current and spectacle correction. And you need to evaluate what's the difference between the current and the old refraction so that you can see if the patient has his refractive error stopped from progressing, because you need to have a 1 year gap when the patient does not have any increase in refractive change before you do any surgery. Then you go on for manifest refraction, which he likes, and then the other is cycloplegic refraction with use 1% cyclopentolate. Then you go on to external examination. We need to do ocular motility to check for any phorias, any tropias, cross external examination. Meibomian gland examination is very important. People have Meibomian seborrhea or they have blepharitis. These are patients, when you do LASIK, they can get debris from these stuck between the flap and the bed. Then you go on to Jones basal tear secretion rate, because then you need to ask them in history, do you have any history of dry eyes? Especially if somebody has a history of dry eyes, it's relative contraindication for refractive surgery. Topographic analysis gives you an idea of if there's any keratoconus present, and what is the topographic analysis, and is there a match between the astigmatism which you see manifest and which is seen in the keratometry reading. There should not be a lot of difference, should be not more than 1 diopter of distance between the astigmatism. Here you see 2 types of keratometers. It is important to know that the manual keratometers usually are not used, or they are absolutely not used for refractive surgery, because they only measure the central 3 mm corneal curvature. Instead, we use corneal topography machines, which are the only way to uncover early keratoconus. The corneal topography machine started with video keratography. Then the most important thing is pachymetry, because you need to know how much thin the cornea is, because you need to calculate the residual bed thickness of the cornea, because if you do surgery and the residual bed thickness is below a critical limit, then the patient is more liable to get ectasia or keratoconus. Then you need to check for corneal topography, which we've discussed before. The advantage is it can provide thickness measurement throughout the cornea. Then we go on to systemic contraindications. Number 1 is diabetes mellitus if corneal sensation is not intact. Pregnancy and lactation, because that produces a lot of changes in the corneal thickness. So if the patient is under those conditions, he is recommended not to have refractive surgery 6 months before and after. Usually 6 months after pregnancy or lactation. And especially if somebody is planning on pregnancy, that is the time you should count that you should not have refractive period surgery during those times. Then you have autoimmune connective tissue disorders, because they've got poor healing, including rheumatoid arthritis, SLE, peripheral polyarthritis nodosa. Then you have immune deficiency disorders. Abnormal wound healing is also seen in Marfan syndrome, Ehlers-Danlos syndrome, and keloids. Keloids tend to produce excessive healing. They tend to produce more haze after cataract or refractive surgery. So they are absolutely contraindicated. Systemic infections, HIV and tuberculosis. Drugs such as azathioprine, steroids, because they produce reduced healing. Antihypertensive drugs such as amiodarone, and anti-acne drugs such as isotretinoin or Accutane. Because recently I had a patient, she said, "Doctor, I'm taking hormonal medicine, I'm taking this Roaccutane for acne." I said definitely you cannot have surgery at this time when you're using these medications, because they're going to adversely affect your outcome of refractive surgery. Then we come on to ophthalmic contraindication, disorders that may be exacerbated by PRK, herpes zoster, simplex as well, which can be reactivated by refractive surgery. Glaucoma, because if somebody has glaucoma, if it's early glaucoma, you can consider it, but even those patients need to be on having minimal damage. Otherwise, it's a relative contraindication to have refractive surgery. Dry eyes, keratoconjunctivitis cecal, exposure keratitis, lid disorders, they are all contraindications for refractive surgery. You need to remember that after refractive surgery, the corneal thickness will change. It will become more thin, and the intraocular pressures, if a patient has glaucoma, they will come lower down because of thinning of the cornea. The pachymetry is reduced, thereby you will get abnormally low readings of the intraocular pressure in these patients. So you have to compensate for that in these patients. Ophthalmic contraindications include otherwise abnormal corneal shape changes induced by contact lenses. So if somebody's wearing contact lenses, you need to ask them to discontinue them for at least 2 weeks, because the corneal contact lenses tend to flatten the cornea, and that tends to miscalculate your topography readings. High irregular astigmatism, that produces higher aberrations as well. Corneal ectasias, which include keratoconus, keratoglobus, and pellucid marginal degeneration. We need to recognize that corneal topography, number one aim is to exclude keratoconus. Keratoconus can be asymptomatic in the stage which is called form-fruste keratoconus. So that can be easily identified by doing corneal topography. Other ophthalmic contraindications include uveitis, which is obvious. It's a disease which can have disastrous consequences for the patient and is not suitable for this surgery. Lenticular changes in cataract, because obviously once you do refractive surgery, the IOL formulas needs to be different to calculate intraocular lens power in these patients. So if somebody's got cataracts, it's better to discuss with him refractive cataract surgery rather than discussing refractive surgery. Progressive retinal dystrophies, myopic degeneration. In these patients, diabetic retinopathy, retinitis pigmentosa, and retinal detachment. Obviously, if somebody's got lattice degenerations, you need to do laser or peripheral retinopexy for these patients, especially when they're having LASIK surgery done, because when you apply the suction in those patients, the intraocular pressure goes momentarily high to 60 millimeters of mercury in those patients. So especially important, patients with glaucoma, early glaucoma, even if they think about refractive surgery, the only surgery they can have is PRK, because they are not suitable to have their intraocular pressure taken up by suction rings. Similarly, patients with retinal problems or retinal breaks, when you increase the intraocular pressure and the suction ring is applied, there is some distortion of the eye, and that can cause problems or breaks in the retina. So they need to have retinopexy done for these patients. Then we come on to radial keratotomy. That was started by Fyodorov, a Russian national, is accredited with the development of modern RK. Although it's an outdated procedure, but still you get MCQs from this, and you need to have an idea about for what refractive error is would use and what sort of problems you use to get with this procedure. So it involves radial cuts on the epithelial side of the cornea to the stroma with a diamond knife. So we'll show you in the next slide. It's a diamond knife which is guarded, and you need to go to a certain depth of the cornea to get that effect in the cornea. So the pattern is spokes of a bicycle wheel. So and depends how many cuts you want to do. The principle is you give an incision to the side of the cornea, not in the center. So if this is the center of the cornea, you'll give incision on the side, and this causes the central cornea to flatten and the peripheral cornea to bulge like this. So the center is going to flat and the peripheral bulges, and that produces reduction in myopia. So here you can see the guarded diamond knife is used in refractive surgery. So it goes to about 80 to 90% of the depth. and this is the guard which you place in so that the diamond knife does not go full thickness, because sometimes it's a complication of astigmatic keratotomy and radial keratotomy that you've gone full thickness. In order to prevent that, you need to have corneal pachymetry at different points before you do this procedure, so you can set the guard of the diamond knife at that thickness which you go. The length of the knife blade and associated depth are set based on the corneal thickness which we discussed, and the ideal depth is about 85 to 90% of the corneal thickness. RK is suitable for only patients with having -1 to -1 to -4 diopters of myopia. So it does not cover as much big range as you would have for PRK or LASIK, which will go up to -8 or 9 diopters. Treatment of higher degree of myopia often requires more than 8 incisions and longer incisions with smaller optical zones. So obviously when you go on to have the radial cuts in a smaller optical zone, that is going to produce those starburst phenomenon which you get in these patients. So what are the complications which you get in patients with RK? Diurnal fluctuations. The cornea gradually steepens during the waking hours. So when they wake up, usually the cornea is flatter, and then it tends to change with day. So under and over corrections, increased astigmatism, instability of refractive correction with hyperopic shift. It is important to remember these patients get hyperopic shifts and not myopic shifts. Perforation of the cornea. It can be having peroperatively or even sometime later as well when they're having cataract surgery or any other procedures later on. Traumatic globe rupture is very easy. So patients playing squash or cricket, contact sports, if somebody touches their eye or somebody punches their eye, obviously cornea is weak and they're going to have an easy perforation. Bacterial keratitis can go, the bacteria can lodge into those grooves which you've made for the keratotomy. And then you come on the starburst and glare due to scattering of light from the radial incisions of the scar, more commonly in patients with smaller clear optical zone. The nearer you go to the center, the more starburst you will get. Contraindications of radial keratotomy was who have a night driving because of glare, sports and person of security personnel because of traumatic globe perforations. Here you can see the different types. One is the starburst phenomenon and the other is the glare which you get around light. Then we go on to astigmatic keratotomy, or which is called AK. For astigmatism, only 1 to 2 transverse relaxing incision, mid-peripheral corneal incisions, arcuate or straight fashion, perpendicular to the steep meridian, and localized ectasia of the peripheral cornea and central corneal flattening. Here you can see you can give them in the periphery. Usually they are near the limbus and they are arcuate. So they can be arcuate. If you go near the limbus, they can be more flatter. The more central you come, the more amount of astigmatism you can treat. And then you know that you need to have nomograms which tell you that this amount of astigmatism will need this millimeter arcuate incision or horizontal incision, so much millimeter away from the limbus. And then you need to have keratometry before these and pachymetry, so you need to know how thick your blade will go. They may be combined with LASIK, PRK, LASIK or cataract extraction. Especially in older times when there was no toric IOLs, this was the best option to do in cataract surgery. Do cataract surgery and you overcome the astigmatism by using a radial keratotomy or astigmatic keratotomy. Here you can see the mechanism of astigmatic keratotomy. So you need to know the axis, and this is the coupling effect which produces this refractive change which you get in these patients. You're basically producing peripheral bulging and central flattening. Then we move on to lasers. So the lasers which we have is excimer laser, which is argon fluoride gas which is used, and it is photodisruptive procedure which works at a wavelength of 193 nanometers. Then you have solid state diode laser which is 680 nanometers, and femtosecond ND glass which is 1053 nanometers. The excimer laser, the acronym is for excited dimer. So it's a dimer of inert gas, argon or xenon bound with a halogen, fluorine or chloride. The combination diatomic gas halide, temporary excited state, and during decay emits UV light of 193 nanometers. So, a removal of control amounts of tissue with extreme precision, act by photo disruption and used for corneal ablations in refractive surgery. But you need to know that the machine which uses the argon fluoride that needs to kept at an optimum temperature, so air conditioning needs to be working in the operating room for where the refractive surgery or the excimer is housed, in order to keep it at the working level, otherwise it will not work. So you need to keep the humidity and the temperature control in those environments where the refractive machine is placed. So the air conditioning is working even when there's nobody in the room or when there's no patients in the room. The advantages of non-excimer solid state laser is there's no toxic excimer gas, wavelength closest to absorption peak of collagen, less thermal and collateral damage, better pulse to pulse stability, net absorbed by air, water, tear fluids, so less sensitivity to humidity or room temperature, and no purging with inert gas required. Although these are the advantages, but still currently the norm of treatment which is preferred by the refractive surgeons is argon fluoride, the traditional excimer laser. The photoablation causes extremely high absorption of coefficient at 193 nanometers. Photon has a sufficient energy to break carbon to carbon and carbon nitrogen bonds of the peptide and corneal collagen molecules. Collagen polymer ruptures into small fragment and a discrete volume of corneal tissue is removed. So you can plan how much thickness. Usually for every 12 microns you would remove one diopter. It varies with different machines if you're using a tissue saving technology or not. And then ablation per pulse is dependent on the radiant exposure, typically with a range of 0.1 to 0.5 pulse at a radiant exposure of 50 to 250 millijoule per square centimeters. On the other hand, the FEMTO laser is an infrared phase laser with 1053 nanometers. Each pulse of focused light lasts approximately 10 minus 15 seconds. High power as pulse time very short. Penetration power is more wavelength according to more wavelengths. So what a femtosecond is basically a cutting laser for which you use, and the important thing, if this is the corneal thickness, and if you want to make a cut in the center of the cornea, you can do that with a femtosecond laser without even doing anything to the area in front. You just need a transparent area. So the femtosecond will make a cut over here, and you can make two cuts in two different layers and remove a lenticle of the cornea as you would do in SMILE. We'll discuss later. The mechanism of action is principle of photo disruption. Laser energy is absorbed by tissue, which results in plasma formation. Excimer was carbon to carbon, bonds were disrupted. Expansion of plasma creates cavitation bubbles which separate tissue planes. So you'll see when you're actually doing femtosecond laser, you see bubbles being formed, or when you're doing, especially in patients when they're having femto cataract surgery. Here you can see the important thing which you need to remember is that the femtosecond laser always requires a docking. It cannot be applied without a contact lens. So it's different from an excimer laser. So in order to produce a reliable contact with the cornea, you need to have a contact lens, and that is a disposable contact lens which costs a fortune. So the machine is attached with the contact lens in front, and the contact lens comes in. Either it can be a handheld machine such as the LDV or the Zimmer LDV, or you can have other machines such as the Alcon machines which slowly come in, or the Zeiss machines which slowly come in and dock onto the cornea. So once they dock on the cornea, the important thing is then they produce a suction to maintain that contact while the femtosecond surgery is being done. So that is important. We'll show you what happens, a picture of the contact between this area. So that is important to remember, and these are the laser bubbles which are produced by the femtosecond laser. So photorefractive keratectomy was first widely used procedure with excimer laser in 1987. So next we go on photokeratectomy. The outer layer of the cornea is removed and then laser is applied. Vision improves as surface heals after 4 to 7 days and discomfort present during healing and cause corneal scarring. Then PRK is the procedure of photorefractive keratectomy. Photo is a procedure in the cornea is reshaped using the cornea using an excimer laser. Usually what you're doing is producing a thinning of the cornea, thereby reducing the converging capacity of the cornea. Thereby the rays of light which used to go focus over here, they go down and they focus further down, and they tend to get a relief of myopia. PRK involves epithelial removal and photoablation of Bowman's membrane and anterior corneal stoma. Surgical treatment of myopia. It's mostly myopia and astigmatism. Hypermetropia is very limited degree, and that is for about 1 diopters. So the important thing to remember when you're doing a PRK, especially over here, if you see, when you're doing for myopia, this central area, you get thinning in the center. So it's becoming like a bowing backward or convex backward of the cornea. If you are doing a hypermetropic PRK, you're going to do a peripheral, mid-peripheral abrasion. The central area is not affected. It is the mid-periphery which affected, which causes the cornea to be reshaped like this and causes the cornea to become more convex in the center, and so that it reduces hypermetropia. Next is LASIK, in which you are going to use a flap and then which is turned over, and then with that you can do the ablation with the excimer, and postoperative pain and scarring are less in these patients. So the PRK procedure, the steps would be: you put topical anesthesia, you remove corneal epithelium, which can be removed manually with a hockey stick knife, and you can use an excimer laser now, which is called trans PRK. Patient asked to fixate to an aiming beam laser, usually or excimer laser ND/YLF picosecond, apply to ablate Bowman's and superficial stromal layer. Mitomycin C 0.02% is sometimes applied for 10 to 20 seconds to reduce the postoperative haze. It is very important that you use it, the mitomycin, only in the area where the ablation is done and not go beyond it, so that it does not retard healing. Then you irrigate copiously with saline, and contact lens is placed there for 7 days to prevent pain for the patient. But the important thing to remember or to tell the patient is, with PRK, within the first 24 hours you will get pain, and to reduce the pain you give topical pain or topical non-steroidal anti-inflammatory drugs as painkillers. You give systemic painkillers, ibuprofen, and you ask the patient to take some tablets such as Lexotanil or Lexilium, which will cause them to sleep, because the main thing is for the patient to lie down in a dark room and spend that night so that he can recover. Usually the next day they are doing pretty well. And here you can see the step. Initially you remove the epithelium using a hockey stick, and in order to demarcate where you're going to remove, so you decide how much is your ablation diameter. So it's very important to check the preoperatively pupillary size of the patient, especially in dark, to see how wide it becomes. If the pupillary size is pretty big, more than 6 millimeters or 8 millimeters, you will not go for refractive surgery, because when these patients are driving at night, if this is the pupillary diameter is this much and your ablation zone is more than that, you will going to get in that area between the pupillary diameter and your ablation zone, you're going to get, so if the pupil is bigger and your ablation zone is smaller, you're going to get that area where you're going to get diffraction of light and produce halos around that area. So use a hockey stick in a predetermined area, and then you would use a laser and then put a contact lens after that. So post-op care is topical antibiotics, topical steroids, topical non-steroidal anti-inflammatory. The topical antibiotics used for about initially 2 weeks or 3 weeks. Topical steroids are used for 6 weeks. Topical non-steroidal inflammatory are also used about 2-3 weeks. And teardrops are used for 3 to 6 months depending on what the patient's response is. But usually the patient is told that you can get dry eyes and you can need to use lubricants for 6 to 1 years. The reason is because when you're doing refractive surgery, you ablate the corneal nerves, and those corneal nerves, they regenerate, but until they regenerate, they tend to produce dry eyes. Vantage contact lens. So what are the complications of PRK? Obviously, number one is pain, and you can get decentration of the ablation zone, corneal haze, and then you get corneal night glare and halos, delayed epithelial healing, central islands. You can get central island where the ablation does not happen, especially if the patient is moving, which has been reduced quite a lot by using machines which have got very good tracking software. Tracking software used by NASA, so that's how accurate the tracking machines are nowadays for the lasers. You can get a corneal ulcer, diminished corneal sensation, and increased IOP. This is a starburst phenomenon, and this is a halo around light. And this are the haze which you can get in these patients. So this is very important. These are the problems which a refractive patient can get, and you need to see these post-operatively. And some of them you'll explain, and some you try to exclude, night glare and halos, by checking the pre-op pupillary diameter. Delayed epithelial healing and central island. Delayed epithelial healing will occur if you use too much mitomycin, if the patient had systemic diseases which reduce healing. So those are important to rule out before. Corneal ulcer, you need to be very meticulous. As little contact with the cornea during surgery as much possible to reduce corneal ulcer or any problems of infection. Increased IOP happens in these patients post-operatively, not because of PRK, it is because of steroids. They are myopic patients, and myopic patients are more prone to get raised intraocular pressure. So typically that will happen about 3 to 4 weeks. Sometimes the patient will come in, doctor, I was doing very well, and suddenly I get pain in my eyes and my vision has got blurred. It was very clear. What has happened? So you check the pressure might be 40 in these patients. So you need to immediately stop their steroids. So it's most important to reduce. What I tend to do is after 3 weeks, I would change them to loteprednol from dexamethasone, so that the raised intraocular pressure does not happen in these patients. Then is LASIK or laser in situ keratomileusis. LASIK or LASIK reshapes the cornea using a laser beam. So there are two steps. One is making a flap, and then to do the laser as a regular PRK. Introduced by PRK in 1949, and corrects vision by altering refractive power by calculated change in the corneal curvature. Used to treat low to high refractive errors, including astigmatism. It initially started for higher refractive errors because found that with PRK you tended to get haze because of excessive scarring when you used to do -8 or -9, because at that time mitomycin was not being used. So LASIK historical preview. PRK was first described lamellar refractive surgery in 1949. Dr. Ruiz introduced microkeratome propelled by gears and keratomileusis in situ in 1980s. Dr. Leo Bors performed first keratomileusis in situ in 1987 in the US. Borato reported use of excimer laser in situ after a cap of corneal tissue was removed. And Palikares' idea of combining precision of excimer lasers with lamellar corneal surgery. LASIK was introduced and developed at the University of Crete in Greece by Palikares, and Wavefront guided LASIK became available in the US in 2003 after it is approved by FDA. Usually these lasers they tend to get approved more quickly in the European countries compared to the USA, where the FDA has got very strict regulations. So LASIK patient selection above 18 years of age, stable refraction at least for 1 year, healthy cornea, contraindicated in inadequate corneal thickness, less than 450 microns, you will not do it. Keratoconus, other corneal diseases such as pregnancy, lactation, and medical conditions which we discussed before. Contact lens wearers to discontinue lenses for a few days prior to examination and surgery. So what you're doing is probably, if you've seen a carpenter using his saw to thin out a piece of wood, you see the shavings that come out from his machine when he's doing that. So that is the basic concept of LASIK. So initially it started with a keratome in which there was a space between the blade and the housing in front, and when it moved over the cornea, it would produce a flap of the cornea which was initially hinged temporarily, then it used to be down up LASIK, so it went to different stages. So LASIK examination, visual acuity, slit lamp examination, intraocular pressure measurement, measurement of pupillary size, corneal topography, corneal pachymetry, cycloplegic refraction, and indirect ophthalmoscopy for retinal examination. These are all the things which we've discussed before as well. So the LASIK surgical procedure is slightly different. So you need to give anesthesia, you need to mark the cornea so that you can mark it at 6 o'clock or you can mark it at 2 places at 5 or 7. That is to have a idea where when you put your flap back that those areas where after the LASIK they should align to the same point where it started off, so that prevents stria formation and problems with the flap not being in the right place at the end of surgery. So fixation of suction ring to raise the intraocular pressure to about 60 to 65 millimeters of mercury. Cornea is moistened for BSS for smooth movement using a microkeratome. A thin flap of 130 to 160 microns of corneal tissue is raised. Suction pressures is removed. Flap moistened, surface dried, excimer laser reshaped the cornea by removing a predetermined precise amount of tissue. The cornea flap is repositioned nasally. So then was a time when it used to be nasal temporal flaps. So here it is, the flap is created and the flap is lifted, and this is laser sculpting, and on the end of sculpting you put the flap back in place. So the LASIK flap, the microkeratomes had their evolution over time. So the first generation it was just linear cutting, the second generation translational plus rotational cutting, third generation oscillatory and perpendicular cutting, and fourth generation laser bladeless hydrokeratomes were introduced. So they started off with reusable keratomes, they came out with disposable keratomes, and it was actually the blade that needed to be changed every time when you're doing LASIK. But this is the basic procedure. This is the suction ring applied, this is the microkeratome, and this is what I was explaining before, like a machine which the carpenter uses. So it goes on, it slides on the cornea on this slide or a glide on the side. And the main problem, or one of the problems of this surgery, was suppose if the electricity goes or somehow the hinge or does not move forward, it gets jammed, you would to have an incomplete flap. So if you have an incomplete flap, you just put it back and then go back and then revisit surgery after 6 months after doing corneal topography. And then other thing was, if you did not go through all the way or it went more than it should have gone, you could get a free flap in these patients as well. So those are the problems. Here you can see the flap being lifted up. This is a down up flap, so you lift up from the down and it used to go upward. But now with technology has improved, now you've got the FEMTO LASIK. Now you've got the flap being created by FEMTO laser. So you marking of the cornea, you docking of the laser with the cornea. Here you can see this is what you see of the contact lens from inside. I showed you before that the contact lens was placed on the surface of the cornea, but this is what you see through the machine. So what you need to do is make sure that the center, you can see these dots. So this tells you that you should align your pupil to the center. So the suction should be central. So once you've achieved suction, here you can see the machine showing this is the suction be achieved, and then it shows that the LASIK is in being progress. So once the suction has been achieved, you go in for LASIK, the machine shows these cuts which are being made, and once you've made the cuts, you are going to lift up the flap with this spatula. So you go in from the temporal or nasal side and lift the flap, and then you lift it from below and you lift it above, and while you're doing surgery you keep the flap upward, hinged upward, do your surgery, then you wash the bed and then you wash the undersurface of the flap. So you do not want any debris between that interface, and then you need to smoothen out the the flap over the cornea, and it is the endothelial pump in the cornea which produces that negative pressure of fluid in the cornea that produces or causes the flap to come into place. Here we'll show you a clip of LASIK being done. So this patient is draped after being cleaned with iodine, and the speculum has been placed, the eye is thoroughly washed, courtesy of Dr. Qasim Latif, and this is the marker for the cornea, so you know where you're going to bring back the flaps. You rinse the cornea again, and then put local anesthetic drops, dry off all the excess fluid from that area around the eyeball so that there's minimal hydration. So once that's done, you can see the picture coming up on the Femtosecond Laser map, and here the laser has been placed, and now you can see the contact through the contact lens of the Femtosecond Laser. It's being moved down, and here it touches the cornea, and the fluid goes out from between the lens and the cornea, and here you can see the pressure has been maintained in green, so it's okay. So now you start off, once the pressure is adequate, you press start treatment, and here you can see the circular lines telling you the flap is being created. So the flap is hinged superiorly. So this is the way the flap is created. First it creates some circles, then some vertical lines. And once the flap is complete, then we'll release suction and then lift up the flap. Here, as you say, the suction has been released. The femtosecond goes away, and then the flap is lifted up with a spatula and go on to a higher magnification to look through the cornea, and initially you have a separator which goes in and finds the plane. So this is the plane between the layers, and here once you've entered that plane, you can enter on the other side. You just lift that up where the flap is, and then you have that spatula, or with the irrigating spatula, in which you go in from superiorly, go inferiorly, and remove all the adhesions, and then nicely lift up the flap superiorly. So once that is done, you're ready for your laser. Here you can see the laser. There are two convex half circles, so they need to be aligned one on one side of the other. So here you can see those two curved lines are aligned, and this is the red lines you see. This is the excimer laser being done, and once that's been finished, so you move it. So here the laser is still being applied, so it's been completely done. So that was after finishing the laser. You thoroughly irrigate the bed, and then you will put the flap back into the place. So this is the time when you're very careful to remove all the debris to prevent that deep lamellar keratitis. So once the flap is in place, the next step is to remove, or to go in and hydrate again in between the layers. And once that has been done, the next step at the end would be to flatten the flap over the surface of the cornea, first downward to up and then side to side. And this is the time when we remove all the striae in the cornea, and then you look through the slit lamp as well later on to see that the flap has joined to the cornea. And this is the end of typical surgery in these patients. LASIK post-management antibiotics and corticosteroids are used probably for less time. I've written 4 to 6 weeks, but people use them for 3 weeks as well. Tear supplements are used as well. You return 1 day, 1 week, 3 weeks, 3 months, and 6 months. Avoid water in the eyes. No shower, hot tub, or swimming first 2 weeks. Swimming is avoided for 2 months. Wear protective gear in any contact sports, because the flap can get displaced. I tell the patient not to rub the eyes. Definitely not. You can get dislocation of the flap for at least 2 months. Enhancement, retreatment can be done 3 to 6 months later after adequate stabilization of the flap. Actually, you can go and re-lift the flap when you do the surgery. That is the exciting part of it. LASIK intraoperative complications, you can get an incomplete flap, premature termination of the microkeratome advancement, inadequate globe exposure. Sometimes people would have a very convex cornea. The curvature would be too much. Those are the patients in which the microkeratome could slide over and produce a free flap. That was the days when femtosecond was not there. And patient having deep set eyes with the patient in which the keratome would not get at the right place, and you would get a pre-termination of the keratome because the suction could not be properly applied. So loss of suction during pass, and never reverse machine and then go forward. Penetration to a deeper level than the initial pass. So if it doesn't not go, just go back with a microkeratome and then leave it and then come back later on. Thin flap due to poor suction, difficult to reposition and likely to wrinkle. Buttonhole flap if K reading more than 50 diopters, because as told you, more curvature produces more problem. Ablation should not be performed and lens should be repositioned. LASIK intraoperative complications, number 4 is full thickness resection. Free cap is flat small corneal due to poor suction, small decentered due to procedure aborted, adequate size, well centered, placed on the conjunctiva with epithelial side down and procedure completed if it's of a free cap is of full size. Epithelial defects are prevented by adequate lubrication. So other is central islands, which you see in LASIK, small central elevation, abnormal beam profile, broad beam lasers, particle matter blocking subsequent laser pulses. So it's very important that there should be no fibers, no dust in that room which should settle on the cornea that produces any islands. Decentration current lasers with incorporated eye tracking and iris registration system have very minimized decentration, because decentration is a big cause of halos and poor results after refractive surgery. Under overcorrection. So when you're sitting like a pilot, when you sit on the refractive surgery machine, you need to double, triple check your topography, your refraction, which you've advised to be done on the patient, and to check that it has been correctly feeded in the machine. Nobody is going to forgive you if you put in the incorrect refractive correction in the machine. So excessive or overcorrection, excessive hydration produces undercorrection. So you need to have a dry cornea before you need to do surgery. But if it over dries, is desiccation, overcorrection, and haze. So it's important that timing of the surgery. Once you put the speculum on, things are go. So you need to finish it and you need to keep going. You cannot stop at one point and fumble around, and you can stay around. If you stay around too much checking your things, you produce dehydration of the cornea. And if you dehydrate and you then rehydrating again and again, rehydration will produce excessive hydration of the cornea. So that is important. So you cannot hydrate once you remove the epithelium. Now with trans-PRK, things are much easier. So then you have interface debris, mostly meibomian gland material. That is important to rule out before. Flap displacement you can have in first 24 hours, lifted and repositioned. Night vision disturbances such as halos and glare. Post-LASIK dry eyes with fluctuating vision due to SPK. Temporary neuropathic cornea because of the flap creation. Confocal microscopy, 90% reduction in corneal nerve fibers is seen in these patients, but regeneration occurs after 1 year. So you need to explain to the patient you might need lubrication for 1 to 2 years. Preservative-free drops are important for these patients. You can get punctate epithelial keratopathy as well. The most dreaded complication is diffuse lamellar keratitis, or sands of Sahara syndrome. So it is also called DLK. So prevention of postoperative dry eyes been reported differently in postoperatively. So prevalence can be in about up to 50%, but it can vary from 30% to 15% as well in different studies. So the most important question the patient is going to ask you: the advantages of LASIK over PRK. No or minimal pain, early recovery of vision, residual haze is unlikely, and high myopia is corrected. Then we come on to very important entity, which is called deep lamellar keratitis, or sands of Sahara syndrome. So what happens is, suppose you've created a flap with a LASIK flap over like this, and you've got this bed. So when you're doing surgery, you can have debris which you did not wash out or somehow that remained over there. So when you put the flap back, that debris remains over there and produces inflammation. That inflammation is going to produce inflammation in the deep lamellae of the cornea. That is called deep lamellar keratitis. So if it's grade 1, is mild keratitis, which is localized in the periphery with no or minimal symptoms. Treatment is frequent topical steroids, prednisolone 1 to 2 hourly. Grade 2 is moderate infiltrates extending to the central cornea, causing decreased vision and photophobia to occur. Treatment is frequent topical steroids along with oral steroids to control the inflammation. Grade 3 is clumping of inflammatory cells which obscure the iris details and central infiltrates with a significant decrease in vision. Treatment is topical and oral steroid, and this is the important critical stage, lifting the flap to brush the stromal bed and the flap and the undersurface and irrigation to remove all the inflammatory cells and debris. You need to counsel the patient at the right time that you need to have surgery done, retouching to set things right for you. If you go into grade 4, dense white central infiltrates may be associated with corneal melting and loss of vision. So then we come on to another entity which is called laser subepithelial keratomileusis, which is called LASEK, which is in vogue before. So here you can see there's a ring-shaped area which used to be called a bath, in which you put on the cornea, you put alcohol in this bath for a few minutes, and then you remove the epithelium or you glide it away because it gets very soft and it is easily detachable or can move to the side. So you use it as an alternative to a LASIK. So this was introduced by Massimo Chameleon in 1999 and combined features of PRK and LASIK. So epithelial flap was removed by LASIK, but it did not move forward as well as LASIK. With Femtosecond coming in, things became much better. The LASEK procedure involved anesthesia, then that trephine or that bath in which alcohol was produced was 20% treatment for 1 minute and separation of the epithelium, stromal ablation with excimer laser, and reposition of epithelial flap and bandage contact lens over the flap. LASEK versus LASIK. Advantage of LASIK is thin cornea, less corneal ectasia, flap related complications are present, myopic corrections is much more, aberration is less, and postoperative dry eyes are less. Disadvantages of LASIK are more post-op pain compared to LASIK, and post-op haze is more, delayed recovery. This is actually the post-op haze with which people started not using it. Then there's another entity called epipolis or laser in situ keratomileusis, introduced by Palikaris in 2003, same as LASIK, except epithelial flap is created with an epikeratome, which is shown here. The epikeratome moves slowly of the cornea and with better control, with plastic or stainless steel made separator pushes away the flap with better separation. So advantages of LASIK is use of epikeratome placed use of alcohol, which is toxic, results is less pain, faster healing, and less corneal haze. So this was the advantage of this procedure. So wavefront guided excimer laser is used to correct higher order aberrations in addition to spherical-cylindrical corrections. So Zernike, polynomials, and Fourier transforms are used to analyze the ocular wavefront and the wavefront. So this is a wavefront which goes to the cornea and which is guided. Custom ablation produces better results in terms of visual acuity and post-contrast sensitivity. Optical properties and image qualities are much better. So the types of ablations which you can get is corneal topo-guided ablation, wavefront guided ablation, or C-LASIK based on both. So corneal topography you use an orb scan or a pentacam, and wavefront you use a wavefront aberrometer to measure the distortion of light wave in optics of the eye by the principles of Hartmann-Shack and Schring and ray tracing. So C-LASIK, this is what we are talking about. This is laser beam which is incoming wave and which goes into the eye, and then it analyzes the light coming out, incoming and outgoing waves are analyzed, and the difference is created. Here you can see the difference, and that tells you what type of higher order abrasions are present. This is the Wavefront Hardman-Shack principle. So these are the different types of wavefront aberrations, which can be they can be astigmatism, they can be aberration, they can be defocus aberration. So these are the different types of aberrations which are present. They can be lower order aberration and they can be higher order aberration. So these are the second order, third order, fourth order, and the Fourier shapes in which you can define the different types of wavefronts. So this is what you treat. So the procedure of C-LASIK is measurement of optical aberration, linking of data to the laser machine. So the topography machine is linked electronically with the laser machine, and laser ablation with C-LASIK system consists of corneal topography and wavefront aberrometry system, flexible laser delivery system, and eye tracking system. So the commercially available systems are Xioptics, in which you have the XiWave, ObScan, Xilinc, and Technoglass laser. You have the ORK CoreWave system or the Nidec Navex LASIK system. The advantages of C-LASIK is higher quality vision, free of night glares, halo improved contrast sensitivity, supervision 6x4, less invasive correction of irregular astigmatism as well. Now we come on to the latest technique, which is SMILE, which is small incision lenticular extraction. Following flex, this was another surgery which was started off before this, in which you had a femtosecond lenticular extraction. A new procedure called small incision lenticular extraction was developed, which involves passing a dissector through 2 to 3 millimeter incision to separate lenticular interfaces, eliminating the need to create a flap. It gained popularity following the result of first prospective trial in 2012. So the flex procedure. The all-laser flex procedure consists of 4 steps. The refractive surgeon uses the lasers to cut a small lens-shaped segment of the tissue, the lenticule, with the center of the cornea. The surgeon then makes a flap in the anterior cornea with the laser, similar to the flap created in all-laser LASIK. The flap is lifted and the lenticule is removed and discarded. The flap is repositioned as in LASIK. So what you're doing is you're removing that lenticule, but in order to remove the lenticule, you produce a flap to take out the lenticule out. While in SMILE, you do not produce a flap, you just produce 2 cuts with a femtosecond laser, then you just give an incision with the femtosecond laser through which you can go inside and just take out that lenticule. The SMILE procedure, the corneal flap is eliminated. Instead, a small incision is made in the mid-periphery of the cornea with the laser, and the lenticule is removed through this self-sealing incision. Flex may induce fewer higher-order abrasions than LASIK or PRK for sharper vision overall and especially at night. Flex may be more accurate than LASIK when correcting relatively high amounts of. Here we're going to show you a clip of SMILE procedure. You're looking through the contact lens of the femtosecond laser. You're seeing it through the operating microscope, and you can see the light blinking over there, and the contact lens is going to be gradually reduced onto the cornea. So you have to be very precise, bringing it down so it touches on the surface of the cornea, and as soon as it touches, you will see a wave of fluid which goes away from in between the cornea and the lens, and you've got contact. So that's where you go, good contact, and once the contact is maintained, you apply suction, which is about 60 millimeters of mercury, and once that is adequate, you go ahead and press for your laser. So laser starts. Here you see the micro bubbles we mentioned before. So you start from outside to inside. So it is producing one layer of dissection, and the second layer of dissection is going to be the second wave going from inside to outside. So in this way, you've actually dissected a lenticule of one is superficial and one is deep cut you've made. And once you've made the cut, then you've got that radial cut from where you can, arcuate cut from where you can remove that lenticule. And here you can see the docking is removed, the lens is removed, and once that's removed, you can see the cornea with a microscope, and you can see the area of the conjunctiva where the docking took place. You can see slight congestion and some marks over there. So that tells you that suction was adequate. So now you've got a separator which separates the initial incision so that you can put your dissector in between. So this is the initial opening you make, and once you've entered that area, then you need to have your dissector ready, which is a spatula. Always want to separate the anterior lenticular first. If you don't, the procedure can become quite challenging because there'll be nothing left to tether the lenticule down. And that spatula you initially would go for at one layer of dissection, and then would be a second layer of dissection. So this can go for a superficial layer dissection and then a deeper layer dissection. So you need to know the planes well, and you need to go all the way to the end of dissection so you can remove all these small adhesions with the femtosecond laser. The problem is that once the adhesions are removed, just go in with a forceps and you remove the lenticule and you're done with surgery. Myopia. So indication for SMILE is age 21 years or older, corneal thickness more than 450 micron, stable refraction for at least 1 year, best corrected 20/30 in both eyes, normal corneal topography, myopic refractive error, and regular astigmatism. Exclusion criteria would be corneal thickness less than 450 microns, topographic or clinical evidence of keratoconus, hypermetropic refractive error, mixed astigmatism, concurrent eye infection, past history of herpes infection, and pregnant or nursing female. So the contraindication or exclusion criteria are similar to LASIK. This pre-op clinical examination would be the same: slit lamp examination, manifest and cycloplegic reflection, uncorrected and best corrected visual acuity, applanation tonometry, dilated fundus exam, corneal topography, dry eye assessment, and specular microscopy. The principle of SMILE is here you produce that lenticule with this. So you have a cut anterior and the posterior cut, and then you have another cut over here through which you go and remove this. So here you have this lenticule being removed in the SMILE. Then there's another entity called orthokeratology, which is being in vogue nowadays. Non-surgical reversible method of molding the cornea with overnight wear of unique rigid gas permeable contact lenses to correct myopia. Initially 8 hours per day and overnight, and after desired correction achieved, you can just use it 3 hours per day. So what you're trying to do is fit something on the cornea which tends to flatten the surface of the cornea and reduces myopia. Orthokeratology indications are any age with less than 4 diopter severe or less than minus 1.5 cylindrical error. 18 years of age, less than 18 years of age, unstable refraction, and a sports person. Disadvantages are longer result time, not a permanent solution because it tends to come back when you stop using it. Cost is high and it's only for myopia and not for hypermetropia. Then we come on to another entity which is called intrastromal corneal rings. Makes use of intrastromal corneal ring segments or intacs. They're made of PMMA. Here you can see those intacs, or this is which is placed. You can place them into the cornea by making 2 cuts, by making 2 or 1 cut, and you can pass this and this rotates through inside with a, once you make that, you need a dissector, special dissector to make that space, or you can do that dissection with a femtosecond laser as well. So intacs, the ring segments flatten the cornea in the way shown here. Somebody spreads his hand and pushes the curvature that produces flattening. So it is used in patients. Use intacs with intralace grooves for intrastromal corneal rings. So intacs indication initially indicated for low myopia, 1 to 3 diopters, and minimum astigmatism less than 1 diopter. Now is advocated for keratoconus as well. Contraindication: systemic diseases, pregnant and nursing mothers, corneal dystrophy, and complications are white reaction, response to steroids, and vascularization. The selling point of this was that if you have minus 1 to 4 diopters of myopia, you can produce or get intacs in. It does not permanently alter your cornea. If there's any problem, you can always remove them back. But it did not somehow sell as much as laser excimer surgery. Then you come on to intraocular refractive surgery. This is the phakic IOL, which I explained before. So you have the normal crystalline lens and you put that lens in between the iris and the crystalline, clear crystalline lens, which is called a contact lens. This is phakic refractive lens. The other is implanted between the cornea and the lens. An angle supported AC IOL is the other option, which is fixated in the iris. Or the third option is iris claw lens. Catch the mid-peripheral iris with a claw, or you can have a PC lens placed in the posterior chamber. Here are the different types of lenses. Here is the AC IOL, which you can be used. This is produced in the sulcus, and this is an iris claw lens, which can be used. So everything has got its advantages and disadvantages. Selection of patients for phakic IOLs: moderate to high myopia greater than -9 and hypermetropes greater than 4.5 diopters. So this is an avenue for those patients who cannot get refractive surgery with laser, where LASIK is contraindicated, such as corneas thinner than 500 microns, steep or flat corneas, and topographic changes suggestive of keratoconus. Tend to get these type of patients in your practice. The important thing with all these patients is, especially in younger patients, you tell them that you cannot do these things before they are 18 years of age. Endothelial cell density should be at least 2250 or 2500 millimeters square. Anterior chamber depth at least 2.8 millimeters. Angle width at least 30 degrees, and no eye pathology except refractive error. So these are the measurements, because obviously they're going to go in the angle, so that needs to be open, and cornea should be healthy for them to have this problem. Surgery advantages are: it is safe, it is predictable, reversible, inexpensive, excellent vision even in dim light, and LASIK can be done for residual error. So this is another surgery in your armamentarium to correct refractive problems in patients. Then we come on to refractive lens exchange. Fukala's operation: extraction of the clear lens. Refractive cataract surgery, phacoemulsification plus IOL implantation, which can be done from -16 to -30 diopters. Indications are presbyopic age with refractive error and cataract, high myopia greater than 10 diopter, or hypermetropia greater than 5 diopter. Contraindications are retinal diseases and occupation as a night driver. The other problem which you need to take in mind, especially if it's a young patient, they might need multifocal IOLs, and those have got the other associated problem of halos as well. So refractive lens is a good exchange, but I will just keep it at the bottom of my list, and it will be more useful for older patients who are getting presbyopic, not to be used much more frequently in younger patients. But obviously, if they've got higher degrees of refractive error, then it is a choice. We see patients, and patients are very fed up using very thick glasses, and they're even happy getting this surgery done. Then you have the multifocal IOL. You get the maximum strength from refractive and diffractive technologies. The strengths of refractive IOL is excellent intermediate vision, 100% transmission of light, and excellent distance vision, while the strength of a diffractive IOL is excellent near vision, good reading speed, and pupil independence. So you need to see how the patient does his day-to-day activities, and then you can decide which type of IOL would be most suitable for him. Then we come on to collagen cross-linkage, in which riboflavin phosphate eye drops are used, which produces cross-linkage of collagen fibers in the cornea, thereby stabilizing the patients with keratoconus. And people are using this in patients with getting early keratoconus. You can use collagen cross-linkage, and then you can do excimer laser. For collagen cross-linkage, use anesthesia, epithelium on or off, 8 to 9 millimeters corneal epithelium scraped off in epi-off surgery. Riboflavin 1% applied every 2 minutes for 30 minutes, and then you can UV rays focus on stroma for 30 minutes. You've got machines, algorithms in which you can do for 10 or 15 minutes as well. Saline wash is applied, and bandage contact lens applied for a few days. Then you come in to conductive keratoplasty, which is a non-laser refractive procedure. Apply low energy radiofrequency wave indicated in presbyopia and hyperopia after 40 years age. You could do it on a slit lamp, and this was much easy surgery, but it did not go into quite in fashion. Here you can see there are multiple points where you produce slight coagulation of the cornea with radiofrequency energy. Gentle heat in the stroma shrink collagen tissues. Tight band formation steeps the central cornea. Correct presbyopia and hypermetropia. 8 to 32 spots applied in the peripheral cornea. Then you go on to presbyopic bifocal LASIK. Multifocal LASIK with palm technology, 8.5 to 9 millimeter flap, and first perform hyperopic LASIK in 5 millimeter optical zone cornea, making the cornea prolate, followed by myopic LASIK in 4 millimeter optical zone. So this is the thing is shown. This is the way you can do a bifocal LASIK in patients. So that takes us to the end of our lecture. Thank you very much for watching. Please subscribe to our channel to get the latest lectures. And I hope you've enjoyed the lecture. It is an exhaustive lecture, but you can watch it at your leisure in different segments and get an idea. We also have a multiple choice question quiz on this, so you can share a link for that, and you will obviously enjoy this lecture much more. Thank you very much for watching.